It's a pleasure to invite Claire Tower to give a talk this morning. Claire is a consultant in fetal and maternal medicine at Manchester Foundation Trust, which used to be known as Manchester Royal Infirmary or St Mary's Hospital. It's probably had more name changes, our hospital, in the last decade than I care to remember. But Claire has trained in fetal and maternal medicine. She is the clinical director of the service, and she and I do a shared clinic on a Tuesday afternoon called the LIPS Clinic, which is for lupus and pregnancy patients, but she also does a joint haematology obstetric clinic, so sees a lot of people with APS in pregnancy. Claire, thank you very much for agreeing to talk today.
It's all right. Hoping we're going to move on from free Wi-Fi.
Here we are. Oh yes,
Maybe.
there's free Wi-Fi, by the way.
Is that yours? Yeah.
That's mine, yeah. There we go. Okie doke. So, this is my day job. So I'm an obstetrician, do fetal maternal medicine. So it's the opposite end of the sort of medicine spectrum to what Professor Bruce does. So I look after pregnant women, scan babies, deliver babies, see women pre-conception, post-conception. Okay, so that's kind of what I do on a day-to-day basis. And I have, as Ian pointed out, a special interest in both haematological and rheumatological disorders, which would encompass antiphospholipid syndrome. So, I'm sure I don't need to tell this audience the definition of antiphospholipid syndrome. You need two bits to it, a clinical bit and a lab bit. So the clinical bit, some kind of complication in the past, be it pregnancy related or blood clot related, and then the lab tests. So just by way of reminder, the lab tests are threefold. They split down into three different things, something called the lupus anticoagulant, something called the anticardiolipid antibodies, and the beta-2 glycoprotein antibodies. And ideally, you would, to meet the diagnosis, would need 2 positive tests 3 months apart. Okay, so I'm sure that's not anything new. So I'm going to focus on pregnancy because that's what I do. Whenever I think about medical problems in pregnancy, it's really nice, I think, to try and break it down. And so I like to split it into groups because that makes it more logical. So firstly, to think about the disease and how it might affect the pregnancy. So in other words, what maternal complications, so what complications might mum get, and what complications might the baby get. Excuse me. And then conversely, what about how the pregnancy might affect the disease? So would it make the disease better, worse? Are there any medicines we need to look at? Does it affect how the disease progresses in the long term? Okay, so it's just a nice, slightly simpler way to focus on things. So I was asked to talk today about planning pregnancy. So I have to say, I like preconception counselling. That's what we call the consultations when we discuss pregnancy. Planning is so important. Whenever women embark on pregnancy, it's always, for me and for Professor Bruce, I'm sure would agree with this, it always more difficult if you're on the back foot before you've even started. So the lady who comes already 15, 16 weeks pregnant with a list of complications in the past and medical problems, and it's just really difficult in those scenarios. You've not had the opportunity to see women before pregnancy, So why is it important? Firstly, it makes me happy, gives me a chance to make things as best as good as they can be. It also gives you a chance to understand the issues that I've got, and also to optimise things before pregnancy. Do we need to change any medicines, anything we need to do about general health? And it's also a chance to talk about the risks and benefits of what might happen, what choices are, and it's always so much better if we see women before pregnancy. Sadly, it doesn't happen as often as I would like. And when I say before pregnancy, I mean before pregnancy, not getting a phone call the week afterwards that goes, oh, by the way, I'm already pregnant, because that happens to me on a regular basis. Okay, so I couldn't do this talk without a slide about the general things. Pregnancy puts the body under really quite a lot of physiological stress, and it's hard work, therefore it helps if you're as fit as you can be before you start pregnancy. And this applies to absolutely everybody, okay? So be as fit and healthy as you can, Really try and avoid pregnancy if you are unwell and if you've got active disease. So, for example, if you've got a recent blood clot or if you've got active lupus, for example, because we know those women are the ones that run into more problems. Try and get those issues resolved and sorted out before you work on a pregnancy. Body mass index, I have to mention. Sadly, raised body mass index and being overweight does not mix well with pregnancy. It increases the risk of every single pregnancy complication there is, from miscarriage to structural abnormalities of the baby, through to fetal growth restriction, diabetes, high blood pressure, everything. Okay? And it's something that we can all do something about. So, unfortunately, in the UK, most women now book a pregnancy with a mass index of above normal, okay, most, so over 50%. So if you can do something about that before pregnancy, then that will improve your pregnancy outcomes and reduce your risk. Folic acid supplements, really important. You need those for 3 months before pregnancy and then at least for the first 3 months. And I also always mention vitamin D, particularly in Manchester. I know it's sunny at the moment, but it isn't normally, and we get a lot of grey weather, and we know that women in pregnancy are often quite low in vitamin D. So if you can address that before pregnancy as well, that's also a good thing. So this is the general stuff. So what sort of things do I think about when I see women with antiphospholipid syndrome? So for me, women fall into one of 3 categories usually. So they fall into the group of women that have been diagnosed because they've had a pregnancy complication. There's also then the group that have been diagnosed, they've had a blood clot or some other medical problem like an autoimmune disorder like SLE. And then there's those women who fall into the third group who have been found to have antibodies, probably in the course of either some infertility investigations or investigations of a miscarriage. Okay? When it comes to pregnancy complications, broadly speaking, those women will sit into 2 groups. There are 3 on there, but they're usually the women who've had recurrent first trimester loss or the late pregnancy complications, and they're broadly different groups. Okay? So, what do we think about? First thing is what effect might the pregnancy have on the disease, if you like, maternal effects. And for me, the biggest issue to discuss is blood clots or thrombosis. And this was one of the questions I think I got given to address in the talk. So pregnancy increases the risk of blood clots for absolutely everybody. And the reason for that is quite logical because when you have a baby, you bleed. And therefore your body has to get itself in a situation where it reduces the risks of that bleeding, and therefore during pregnancy, in preparation for that, your body is changing in order to reduce the risk of blood loss at the time of birth. Side effect from that is that it does increase the risk of you getting a blood clot, particularly as the uterus gets bigger and starts to put pressure on the blood vessels, which means the flow of the blood is less. Okay? So we do know that pregnancy increases blood clots and the risk of that for everybody, although the absolute risk in pregnancy is overall low. So whenever you look at pregnant women, the risk is no more than about 1 in 1,000. So you have to put things into perspective. Yeah. So in a unit like ours, I work in a big unit, we deliver about 9,000 babies a year. We would see no more than about 9 confirmed blood clots in a year. Okay, so it is overall a low risk, but there are things that the risks that might happen. Okay. Whenever you're thinking about women with antiphospholipid syndrome or antiphospholipid antibodies, you have to think about the rest of the medical picture and everything else. And lots of studies are out there, and tend to try and do is homogenise the group, so make everybody as similar as possible, but that's not real life, and we all know that that's not real life. And real life is that people are all different, okay? And therefore we're left with a situation of trying to individualise things when actually what the studies are trying to do is make people not individuals, okay? So I always think of the other problems and what other risks do we need to think about. So is there high blood pressure present? Is there diabetes? Any with kidneys? What about joints? What antibodies have people got? And that's just a list of the examples, okay? So thrombosis risk. The easy bit for me is for women who've had blood clots before. That's a straightforward decision because we know if you've had a blood clot before, you are more likely to get another blood clot in pregnancy because pregnancy will increase your risk, and it probably increases your risk about tenfold above where you would be when you're not pregnant. What we usually do is offer women heparin, which is the injection to take all the way through pregnancy and then for at least 6 weeks afterwards. The risk of blood clots exists right from go, as soon as you've got a positive pregnancy test, all the way through, although it does increase the bigger the uterus gets, and the highest risk period is the 6 weeks after you've had a baby. And if you think about it, that's fairly logical because that's the time that your body is going to bleed, so the risks are highest then. Heparin is a safe drug to take in pregnancy. It doesn't cross the placenta. It's quite a big molecule, so it doesn't thin the baby's blood at all. Doesn't produce any risks for the baby. There are risks for mum because it's an injection. You've got to give it to yourself every day. Some women don't like doing that. Usually gives you bruises. Often you get little lumps under the skin, which again women sometimes don't like. But generally speaking, out of all of the women I look after, they tolerate the injections well. Usually manage to give them to themselves without a big problem. The biggest clinical decision we have is what dose to put people on, whether we give them a preventative dose or a higher dose. And in fact, even around the time of delivery, being on heparin doesn't cause much in the way of problems. Can sometimes affect whether or not you can have an epidural, but it doesn't really seem to cause big bleeding risks. Okay, the only group of patients that perhaps changes in is women on very high doses who end up needing caesarean sections because we do have problems with wounds that sometimes bleed because of the women being on high doses of heparin. Okay, so in women who've not had a blood clot before, perhaps fall into the group of women where the antibodies have been identified for other reasons. What to do in pregnancy is perhaps a little less clear. The RCOG, which are our Royal College of Obstetricians and Gynecologists, produce this document, which is the guidelines for reducing the risks of thrombosis during pregnancy. And it's not straightforward. I think it's fair to say it's probably one of the most complex guideline documents I've ever seen. In a nutshell, what you do is you think about it in the context of everything else. And their general advice is to use the antibodies in the risk profiles, which I'll show you later. So things we would consider is body mass index. If the body mass index is above 35, that would increase the risk. Maternal age, something none of us can do anything about, unfortunately does increase the risk. The number of babies you've had, whether you're pregnant with more than one child, and the clinical history. So in terms of what is the absolute risk, because this is a question I was asked to review, that's a very difficult question to answer. The APLS split antibodies into high risk and low risk profiles. Okay, so the higher risk profiles, the women who would have the lupus anticoagulant, either double or triple positivity. So out of those three, 2 or 3 positive at really quite high titers would fall into a higher risk group than somebody that's perhaps only had a transient antibody or has lower levels of the cardiolipins or the beta-2s. So that's the definition of high and low risk. What is the absolute risk of clot? So if you are a high-risk carrier with no clinical history, it would seem the risk of clot varies between studies. This is over life, not in pregnancy, 10 and 13%, and the EULAR say aspirin might reduce that risk. Okay? What you have to remember with these studies is that they often overstate the risk because they are high-risk populations in the first place. Okay? Similarly, pregnancy, if you've had obstetric antiphospholipid syndrome, so in other words, diagnosed because you've had a pregnancy complication, the risk is broadly similar actually, perhaps 10 to 15%, and again it might be reduced by use of aspirin, but the standard of those studies is not high. What about the risk in pregnancy of getting a blood clot? Again, it's actually very, very difficult to answer that question because all of the studies are women who have been treated. So if you're on heparin, that will reduce your risk of getting a blood clot. And heparin reduces your risk of getting a blood clot by about 2/3, perhaps a little bit higher, 3/4. Yeah. So all of the studies looking at women with antiphospholipid antibody syndrome are all in women that are treated. So it's almost impossible to say what is the risk of getting a blood clot. The way we assess it in pregnancy, so this is a small portion of that big guideline document. So you plug it in as a risk in our risk assessment, and these are the UK guidelines. If you get 4 or more of these minor risk factors, then we would give heparin. If you get 3 or more, you would be offered it from 28 weeks. So this is how we assess. So what about the baby? So there are 3 groups of complications that you can get from antiphospholipid syndrome or antibodies. Firstly is first trimester loss, and then second and third trimester complications, which can vary. The third trimester complications, to meet the definition, is anybody that runs into problems with the placenta at less than 34 weeks. Yeah? And that can be a real mixture of problems from either getting high blood pressure and proteinuria, so something called preeclampsia, the baby not growing properly, which is fetal growth restriction, or placental abruption, okay? And in fact, all of these things can lead to preterm delivery as well. So it's a kind of composite of complications that you can get. So I've got to talk about the placenta. I love the placenta, even though this is it's not a particularly attractive thing after birth, okay? But the placenta is the thing that sustains a baby throughout life, and it is a truly amazing thing, yeah? The development of it occurs very, very early on. So this little cartoon here, pointer's a little bit past its best. So this little cartoon here, so the box is represents the lining of the uterus. Yeah, so the bit of the uterus or the womb that sheds every month when you have a period. This circle here, a cystic structure called a blastocyst, and it's about 6 to 10 days after conception. It buries into the lining of the womb, and the green bit goes on to form the baby. And the rest here, these cells push into the lining of the uterus, push into the blood vessels, proliferate, so grow and change to create the placenta. Yeah, and the placenta. It has to do that in order to sustain the growth of the baby, and it's an amazing thing, because by the end of the pregnancy, this is what it looks like. Again, this cartoon, this bit here is where all the transfer of nutrients and oxygen and energy crosses to the baby. This is the umbilical cord. This space here is supplied by mum's blood. Yeah, so mum's blood will come in through these little fountains, and then these bits here, which are the villi, they're like little trees, sort of wafted in this space. Yeah, and that's where the important action happens in terms of sustaining the baby. Yeah, this is what it looks like on scan at the end of the at about middle of pregnancy. So this is the placenta here. This is the amniotic fluid, and the coloured bit is just blood flow. Yeah, it's the way the Doppler images. So this is the cord. Yeah, so this is what it looks like. So antiphospholipid antibodies, unfortunately, don't appear to be good things for the placenta, and this is probably why you get the increase in risk of pregnancy complications. Those antibodies seem to be associated with, and I emphasise it's an association, not a definite, yeah, because there are some women, in fact many women with antiphospholipid antibodies who will actually sail pregnancy without any bother. But they seem to be associated with less growth of the cells, so those cells that bury in and make the placenta, less migration, so less movement, more death of those cells, and also inflammation. So inflammation is really, really important in pregnancy, because if you think about pregnancy, what has to happen is you've got a baby, but it doesn't share its mum's genes. It's got half from mum and half from dad. So by rights, your body should go, hang on a minute, that's not meant to be there. I'm going to get rid of it. Yeah. But amazingly, the maternal immune system, which is what is there to defend us against infection, not only allows that baby to implant, it allows it to grow. And so the maternal system has to do some pretty amazing things during pregnancy, yeah, and quite possibly antiphospholipid antibodies interfere with that process and mean that those processes don't happen as they should. The other thing that is sometimes associated with it is when you cut placentas after birth, if there's been a complication, you see more blood clots within them. Yeah, so in that space where you'd expect lots of nutrients to be passing, you can see clots, okay? So I got asked, how does antiphospholipid antibodies cause first trimester loss? So we think it's because the way that the placenta develops gets adversely affected by those antibodies. So this is another little diagram, and this is what happens when the formation of the cells from the baby have to interact with the mum. And we think that you get altered growth in these cells, and those cells are more likely to die off, causing first trimester loss. Yeah. What about later on in the pregnancy? So later on in the pregnancy, this is another quite amazing thing. So the purple lines here, that represents the lining of the uterus. The spirally bits here, they're sometimes called spiral arteries. It's a very imaginative name. It's because they look like a spiral. Yeah. And in non-pregnant women, what happens is every month when you have a period, this bit contracts and the lining of the womb sheds. Yeah. During pregnancy, obviously implantation happening up here, and the cells from the baby invade into these blood vessels, and what should happen is that instead of these tight spiral arteries, you get a big funnel shape. Yeah? Can you see how it's kind of completely changed the structure of that vessel? And it's that allows a really good blood supply into the placenta. And we know that in women with growth restriction and preeclampsia, this process doesn't work, and instead of getting a really big flaccid structure, get one that's still a bit coiled up, yeah? And that's how you get less blood flow into the placenta, yeah? And that's quite possibly what underlines some of the thrombotic and inflammatory problems and the reduced blood flow, hence babies don't grow, hence it's not working properly, and you get preeclampsia as well, okay? So that's basically, in simple terms, what we think is happening. So, what about management? First trimester pregnancy loss. This is the only area in antiphospholipid syndrome where there are randomised controlled trials that demonstrate some benefit to treatment. So we would usually recommend low-dose aspirin, low molecular weight heparin, and that improves the live birth rate. Okay. There are, however, quite a lot of studies that show that even though you improve live birth rate, you still have a risk of late pregnancy complications. Yeah. Like growth restriction. What about those late complications? So when you're pregnant, what we would do is have a little look at the way we think the placenta is developing, and I'll try and explain this as clearly as I can. So this is a uterus. It's taken from quite an old textbook. Yeah, uterus is supplied by lots of blood vessels, and the important one we can see on scan is something called the uterine artery. Yeah, so there's two big uterine arteries that come in either side of the, just at the side of the neck of the womb, actually. Yeah, and when the placenta develops and all those blood vessels change from being tightly coiled to big and floppy, it changes the blood flow patterns here, and we can see that on ultrasound scan, and that's something called a uterine artery Doppler. Okay. So in a normal pregnancy, you get a really nice low resistance blood flow. So there's lots of flow going through the placenta, and this is what the flow looks like. So this is when the heart's contracting, and this bit here is when your heart's relaxing, and you get that nice sort of wavy pattern. Yeah. In pregnancies where the placenta's not developed properly and those spiral arteries haven't changed, you get this kind of notchy pattern. Can you see there's like a little notch there? And the difference between this bit here and this bit here is pulled apart, so it's stiffer. So it reflects that the blood vessels are just stiffer. Yeah. And when you look in women with antiphospholipid antibody syndrome, you see if you've got normal uterine arteries, so another look like this, you're pretty likely to do quite well, yeah? So the negative predictive value, that means how likely are you to get a normal pregnancy outcomes over 90%, yeah? So that's pretty reassuring, yeah? What you also have to remember is this is a perfect test. No test we do is perfect, yeah? Is that even if your blood vessels look like this, actually positive predictive value is only 67%. So that means what's the chance if your arteries look like this of having a complication late pregnancy? It's 67%, so only about 2/3. So even when they look like this, we'd still say a third of women are going to do okay. Yeah, okay. So it's useful for reassurance or not, but it doesn't tell you anything for definite. And life tells you anything for definite? Not a lot, really. Okay. So what about management? I'm sure most of you are aware of this. In your first pregnancy, if you've got somebody with persistent antiphospholipid antibodies, but you're asymptomatic, this is always quite a difficult one, I think. Yes, we can give aspirin, yeah, It's a straightforward thing to do. We're not asking women to do very much. Doesn't have much of a side effect profile. It's a low risk thing to do. Yes, with the growth of the baby, similarly. The big question is whether we would give women heparin, because that is associated with side effects for mum, can have some problems. Women sometimes don't like giving themselves injections. And so what we do in this scenario is think about the woman as a whole. Why would we want to give the heparin? There's two reasons. One is for clot risk reduction, and the other is for complications of pregnancy. And really we would just consider everything else, whether they've got problems as well, which would mean heparin would be beneficial or not. What about women who've had complications in the past? Most, I think, would give heparin to women with previous complications and antiphospholipid antibody. Usually it's the preventative dose of heparin, and then we would monitor the baby's growth. Hydroxychloroquine, so this is kind of the new kid on the block in terms of treatment in pregnancy. It's certainly not a new drug, it's been around forever, and it's originally an antimalarial drug, but it's known to be anti-inflammatory. So you remember I said about the inflammation being important in the placenta. It's likely that this is how hydroxychloroquine might work. It's also antithrombotic, so it probably does lots of good things for pregnancy and for the way the placenta develops. And there are some retrospective studies that show that women on a hydroxychloroquine might have a better outcome. And at the moment, it's the focus of more than one trial to see whether it works, giving it before pregnancy, because it takes a while to get into the system and get the levels up. So hydroxychloroquine is becoming increasingly used, although at the moment we're trying to use it in the context of clinical trials, so we get those answers. Although it's thought to be safe in pregnancy, it's not a completely benign drug, and that it can have some problems for mum's eyes, and we certainly have women who don't tolerate it. What about treatment failure? Things we've used, there's steroids. The idea of steroids is that they reduce inflammation in the placenta, but steroids are not a benign drug. I describe them as quite a dirty drug, so they give people lots of side effects. They mean spotty, women gain weight, they put your blood pressure up, which if you've already got a blood pressure problem, can be an issue. It also affects diabetes development, so if you've got somebody who's prone to diabetes, you're going to make all that worse. So steroids are not an easy choice to make. Immunoglobulins have also been tried. I think the feeling is that there isn't a role for immunoglobulins. That's a very expensive infusion. Pravastatin, which the statin we use for reducing cholesterol, have also been looked at, but more in the context of late pregnancy complications, so giving it to women after complications have developed. People have talked about whether it could be used preventative, but there is evidence that that might not be a safe thing to do at present. So, prognosis. I couldn't get through this talk really without mentioning prognosis, and that's prognosis of pregnancy. For the vast majority of women, I'd expect a positive outcome. Unfortunately, we always have to have a candid conversation about being realistic. If you've got somebody who's had lots and lots of problems, it's not fair to raise expectations that we can guarantee a healthy baby. We just can't. For me, the worst case scenario is very premature babies and complications in pregnancy where we've got difficult decisions to make. If we've got a mum who's developed a really severe complication of pregnancy and we might have to deliver that baby and that baby might not survive, or if it survives it has a risk of cerebral palsy and handicap. Those are life-changing decisions for everybody, and we always need to have these conversations. Fortunately, it's very rare, but it sometimes does happen. So in summary, for me, preparation is key. Maybe it's just my OCD, but I like to know what's coming. I like to be organised. Preconception counselling is vital. It makes such a big difference to us because it really is difficult when you're starting off a pregnancy on the back foot. It's just very difficult. I always consider the individual in front of you in the context of the literature, but the literature talks about women or patients in homogenous groups, and that's just not real life, and so you have to consider all of the factors that might apply to that particular woman and that particular family, and one size really doesn't fit all. Okay, and outcomes can be good and generally are very good with preparation and the right management, but it is important to be realistic. I think that's it. Anything you want to ask?
questions, and our roving microphone will be roving again. So please, if you just identify yourself and then ask a question.
Hi there. I'm just going to ask about the dose of heparin. I've done with the pregnancy. I've got 2 teenage girls. That's all good. Second one, I did have a DVT, but I think my team weren't assessing the dose.
Okay.
So is it usual to increase the dose as pregnancy progresses?
So that depends on the reason for giving the heparin and also the woman in front of you. So we know that as pregnancy goes on, you become more heparin resistant, yeah? And so depending on the reason that you're taking it, particularly if you're overweight, there's 2 schools of thought. Some people just routinely increase the heparin dose, either going up to a BD dose, yeah, so twice a day. Other units and other haematologists actually measure anti-10A levels, which is contentious. So that just tells you whether or not you're on the right dose. We find, so I work in a unit where the haematologists like measuring the anti-10A levels, and the vast majority of women, if you're overweight, you'll end up on a higher dose. If you're on warfarin or one of the oral DOACs, so the like rivaroxaban pre-pregnancy, you would need a treatment dose, and we would monitor that monthly. And almost certainly everybody goes up and ends up on a twice daily dose. Yeah.
Hello, thank you for that. Again, personally, I'm done with pregnancy and children.
So am I from a personal point of view.
Just sharing. I did have some links. I was undiagnosed during my pregnancies. So the first one I had preeclampsia, and the second one I had high blood pressure, which was a stroke, and I was diagnosed after that. But looking back, my 2 questions are: is there any link between APS and polycystic ovaries, which I was diagnosed with, and any link with gestational diabetes, which I had in my second pregnancy? But neither of those have come up in my APS diagnosis, so I'm curious.
Probably not is the simple answer, yeah. There is always associations between autoimmune disorders, yeah. So diabetes is usually, or can often be, autoimmune, but they're not. Those are not typical associations that we see, yeah. I think you were just unlucky.
Okay. And one final question.
I feel the need to also declare the fact that I am not having any more children, as we all have. It's like sort of a thing to do. But I just wanted to ask, and this is an arbitrary, this is your opinion, but based on your clinical practice. But Professor Graham Hughes suggested that obviously, whilst it's not economically viable to automatically screen all women who are becoming pregnant, they've got APS, because many don't discover it until they have gone through multiple miscarriages and lost babies, etc. But he suggested that a simple risk-based questionnaire, history of migraines, history of autoimmune disease, blah, 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 and only screening those at-risk patients would be perfectly feasible and economically viable, and obviously save a lot of money on treatment in the long run as well. But him saying this as an expert, and the actual reality of it actually being into fruition, obviously because I've got 3 daughters, I'm thinking about them. Do you think that's likely that will actually happen or not really? This is just your opinion, I do realise that.
In total honesty, I think it's unlikely to actually happen. Just because in terms of a screening test, what you need to have is demonstration that you've got a treatment that is required by everybody and would demonstrate outcome. That's not to say that I don't think it's sensible, because I think it's the case that lots of us, if you've got women that are about to embark on pregnancy and it's a really, really high risk scenario, then actually I do screen for antiphospholipid antibodies in those women, because I kind of think, those women probably have 1 or 2 shots at this. They're already in the late 30s. Do you see what I mean? Yeah. That's just my personal preference, yeah. The whole world of screening and pregnancy is so contentious, particularly in the current economic climate, that I think, we can't even sort out the non-invasive prenatal testing for Down syndrome, nothing to do with this conversation, but, just in the UK, I just can't see that kind of coming in. That's not to say it shouldn't, but there it is.
Great, thank you very much.